when you use different models, which I think many of them are more appropriate for these types of data sets, you see pretty much the same conclusion that hardly any of the measures do we have evidence to say that they did make a difference for decreasing the number of cases. We're not talking about impact on deaths. We're not talking about impact on any collateral damages. We're just looking at number of cases. But even for that, I don't think that we have solid evidence for any of the non-pharmaceutical interventions that they made such a big difference.
Very warm welcome to Professor John Ioannidis. Thanks for taking the time for an interview.
Thank you so much for the kind invitation.
I'd like to introduce you for the audience briefly, because I could take a long time introducing you. But what I will say is you are a professor of medicine, epidemiology, and population health at the Stanford University, one of the most influential epidemiologists in the world, I would say. Maybe we can debate about that. But you're also one of the world's most cited scientists in this field. For our topic, also interesting maybe, is that already 5 years ago, you've been a critic of the lockdown policies and have been warning about the damages these measures will cause to society, especially to a new term I learned, to the non-laptop class. And because now we are, quote unquote, celebrating 5 years of corona measures in Germany, but also worldwide, and you are here in Berlin, I took the time and have the privilege to talk to you. Also trying to basically evaluate what happened, because you have been researching about the corona measures and corona. And maybe we can start by you saying, what was your research field when it comes to corona and corona measures? What have you been studying about this?
Clearly, it was a major crisis, and I think that many scientists tried to respond to this. I was just one among about 2 million scientists who published in the peer-reviewed literature on COVID-19 over these 5 years. We have a vast literature at the moment of about 800,000 papers that have been published, let alone all the media coverage and all the tweets and blogs and podcasts that have been floating around about the pandemic. So I thought that it was a major crisis, a pivotal moment in the history of our societies and also of public health and medicine, and we all had to do our best. So I tried to do what I have been doing all the time, just try to do research and try to understand the epidemiology of a new virus, what it meant in terms of impact, what also our measures and our decision-making might entail, and what might be the consequences. So it was unavoidable. That was my field of engagement. Even before the pandemic, I thought I should try to do what I could.
Mm-hmm. And I read an interview with you, a recent one with an Austrian colleague of mine, where you reflected on, I would call it maybe the climate of debate in that time, in the beginning. And you were talking about top epidemiologists calling you, basically saying we cannot speak up, we cannot say anything contradictory because it would destroy us, is kind of the quote. I think probably they meant their careers. And before we go to facts, I would like to go back to this climate that was prevalent, and maybe you can describe how was the climate also in the scientific debate in the beginning of the corona pandemic, when it came to expressing opinions that were maybe not the mainstream narrative. How was it for you? What did you experience?
It was a very toxic environment, I think, for anyone who wanted to be involved in these debates and try to present some data, some evidence, and speculate about what it meant. I think that people had taken very strong positions, and there was very strong polarization and partisanship and a sense of ideology running the show. So that was not really the best circumstances for doing science, especially for someone who has no political ideology and doesn't want to satisfy one narrative or another. Death threats were very commonplace.
Also to you?
Of course. I think both myself and every single member in my family, uh, we were attacked in ways that I could never have imagined that would be possible to happen. And I think that the environment was so toxic that the vast majority of credentialed scientists who might have some expertise that would be relevant to epidemiology. Of course, it was a new virus, so no one really was an expert on this virus when it all started, but at least people who had the background and the credentials that would be relevant, most of those self-silenced. I think that I've heard from so many people telling me that, John, this is unbelievable. We can't believe that this is happening. If you are attacked in such a way, if we were to try to do anything or say anything, we would be completely annihilated. We would disappear from the map, and our careers would end. Who knows? Maybe we'll be dead. I mean, everything was possible at that time. The way that the behavior of the mob and of politicians and mass media and even legacy media and influencers were operating. And I think this meant that even though eventually we got 2 million people writing about COVID-19, when we needed it, the best epidemiologists just stepped down. Uh, Most of the people who dictated the narratives had no clue about epidemiology. They may have had some expertise, some of them, in some other fields. There were some very good virologists, for example. There were a few people who had good expertise in some other fields, but not really in epidemiologists. I think that epidemiologists were very quickly seeing my paradigm and other people in epidemiology who were equally silenced and destroyed. They moved out and they left epidemiology to people who were not epidemiologists.
What made you stay and speak about it and publish about it?
I think that it could have been obsession. Maybe I was opinionated and wrong, who knows? But I also felt that I had to try to do the best science that I could, because I thought that it was a major crisis with multiple dimensions, and there were lots of things at stake. I think that it would be shameful for me to just say I'm not going to work on this once I started working and doing my first studies in the field. It was something that could make a difference if we made the right choices or the wrong choices. So yes, I'm sorry that I continue to do science. Perhaps some of that was wrong. Perhaps other pieces were more correct than others. Who knows? I think that would take a very long time to arbitrate. But I thought that it was important to try to get as much reliable evidence as possible.
Yeah. And do you, now looking back 5 years, have any idea why it became so toxic? Like, did it just fall from the sky, this toxic environment?
It's difficult to explain. I think it was a process that involved many stakeholders, and it was not just one factor. It was multiple forces coalescing to create that toxic environment. It was a crisis that affected everyone. So in comparison to the typical scientific debates where you have usually experts in a localized field who may tear each other apart with scientific or close to scientific arguments, here we had everybody on board. It was not just scientists. It was everyone who was affected by what was happening, by the pandemic, by the measures being taken. We had very heavy involvement of politicians. We had very heavy involvement of media and social media. So it became an environment where scientists were just a minority of the voices that were being heard. Most of the major narratives were shaped probably with very little scientific input. I think they were shaped mostly by what large contingents of mass media and social media and political influencers just tried to make a response out of a very difficult situation. If you have a situation where there's very little reasoning and a lot of fear, a lot of panic, a lot of agitation, where you superimpose all the chronic differences between people of different ideologies, different political parties, that can become very quickly very toxic. And there's very little room for reasoning, for evidence, for scientific approaches. You have to be part of a clan, and then there's members of the clan who support you, and members of the opposite clan who oppose you. And for a scientist, this is horrible because, personally, and I think that this applies to most scientists, I do not wish to belong to a clan. I've never seen myself as a member of a tribe in doing science. And those who attack you and those who support you may be both a problem, because even those who support you then give a signal to those who attack you that, so that person is a member of that clan and we need to attack him even more. So trying to remain independent and just trying to think in as objective a way as possible becomes close to an impossibility. I don't regret this, because I think that this is what scientists should try to do. I think we should try to remain independent. I think that we should not worry if our results make some people unhappy. I think that if it is what it is, I cannot change my numbers to make one tribe happy or another tribe happy, or some politicians or some other politicians. This meant that during the pandemic, I had some results that made one group happy and another unhappy, and some others that were exactly the opposite. So my findings of relatively lower infection fatality rate compared to earlier expectations or speculations was attacked from one side. My findings when I led an international meta-analysis on hydroxychloroquine, that this intervention does not decrease mortality. If anything, it seems to increase it, attacked the ire of the other side. I'm sorry, I think that in each case, I just tried to do the best that I could, and without having some precondition that I had to find a particular type of result. It was the results that emerged from best intentions and best possible designs. Of course, each study could have its limitations.
Yeah. In Germany, we have, I don't know if you have it too, we have this saying that you don't want to have applause from the wrong side of the theater, kind of. But I understand you, it should be irrelevant who applauses you, because it's about what you present and not what people, like how they behave to what you present.
Exactly.
Yeah.
I think that if a scientist starts thinking about who is going to applaud me,
yeah.
and who is going to scream, and I think it's impossible to do good science, because then you change even your research agenda, you change even the questions that you want to ask, you change even the range of possibilities of results that you can obtain.
Yeah, and I mean, I'm not a researcher, but I of course observed the psychology around it, and would even assume that there's some inner censorship, like, should I ask this question? Should I even bring up this topic? And one of the topics that I really wanted to talk with you, and you mentioned it now, is the infection fatality rate. So millions of people have learned completely new terms they've never heard about, including me. And we are doing this interview basically 5 years after something in Germany happened that is still relevant. Because in Germany, the RKI that you know decided on a weekend, the two people, the president and the vice president, they decided that the risk that is coming from corona for public health is high. But then we had journalists pushing for the reason for this, even in front of a court. So then we got some minutes and protocols, heavily redacted. We talked about this, but later we became them without any redaction through a whistleblower. But basically, journalists always wanted to know on which database, on which evidence did you put up the risk too high for the whole population? Almost at the same time, you published an article that I read 5 years ago that was called A Fiasco in the Making. That it's about, how reliable are these numbers that are being thrown around? Are we all going to die? Is this the new killer virus? And you were very, I would say, moderate, or saying we need good evidence before we make such a claim, but you made some claims. And I would like to start there in a little time travel. So one of the first interviews I saw with you, you made a comparison from the coronavirus to seasonal influenza. And then I noticed, it was also in Germany here, that comparison was not allowed, basically. Looking back now, is SARS-CoV-2 much more deadly or lethal than the seasonal influenza? Is the comparison valid at all? Does it bring anything? What do you say now? How dangerous is the virus?
I think the comparison against seasonal influenza probably is not a good one. And to be honest, I think that I tried to avoid it because we were dealing with a new virus with a lot of uncertainty. So back in these early days, my main point, and the reason that I wrote that article and others at about the same time, I wrote another paper in the European Journal of Clinical Investigation, pretty much in the same week, was that we have no evidence. We have a major crisis. We need reliable evidence. Our evidence to that date was suboptimal to allow us to know what we're dealing with and where do we go next. I think that I had no problem with lockdown in the early decisions because we just didn't know, but that was unlikely to be a situation that would be solved within a week or two. And eventually it was something that lasted for many years, as it was probably anticipated from the beginning. And we had to know how to react and how to adapt our response very quickly with more reliable evidence. Now, retrospectively, we have immense information about the fatality risk of SARS-CoV-2. It has changed over time dramatically. Currently, it is amazingly low, and I think that we have so much immunity protection in the population that you would have to add many zeros in front of any number before you express any sense of fatality from SARS-CoV-2. In the very beginning, I think that the concept was that we have a case fatality rate of 3.4%, which is the detected cases based on the China evidence. And we also had WHO saying that their envoy went to China and came back saying that there's not really many asymptomatic cases, which means that we're detecting everything. And therefore, the infection fatality rate would be pretty close to 3.4%. Based on what we know now, I think that in the very beginning, it was not 3.4%. It was something like 0.3% or maybe even less. And of course, the exact number would depend on what happened in terms of who was infected. So if we had nursing homes infected, it would be very high. It would be even higher than 3.4%. If it were children, it would be amazingly low. It would be very close to zero. And of course, it is possible that we could have some bad outcome in even in some children. But when we look back at what happened in a global scale, children, adolescents, and even young adults, maybe to the age of 25, had fewer deaths during the pandemic years compared to the pre-pandemic years. So, influenza disappeared. We had SARS-CoV-2. the death burden for these age groups eventually was lower during the pandemic years compared to the pre-pandemic years.
And how did influenza disappear?
That's a very interesting question. I think that there's different opinions, and we don't know for sure. Some people argue that maybe some of our measures were pretty effective in suppressing influenza.
But shouldn't they have then also worked for corona if they suppress influenza?
Some people would still claim that they also worked for corona.
Okay.
I think that there can be debate about that. Some others might argue that, well, you have a space, an epidemiological space that needs to be filled with some respiratory pathogens every year.
Mm-hmm.
And each year, different pathogens compete for that space. And during the pandemic years, SARS-CoV-2 pretty much dominated, and all the other viruses practically almost disappeared with very, very low levels of activity. I think we don't really know exactly, but the argument that we have something superimposed and this is just new deaths and new morbidity on top of everything else that would continue unchanged, I think was a very wrong oversimplification, because the background morbidity and mortality did not remain the same. It changed enormously. For some diseases, like other respiratory pathogens, it decreased very sharply. And for others, it escalated. And I think that the escalation was probably our own doing. It was not really SARS-CoV-2 that led to an increase in deaths from overdose, or an increase in deaths from alcohol, or in other situations that affected our well-being and health in grand scale.
Mm. That's still one of the things journalists, I don't know if they do it intentionally, but they do wrong. They say how corona has affected the children, and then they talk about their psychological problems because of school closures and don't mention the real cause. It's not corona, it was the measures. So there's still, I would like to, one thing that I found interesting, because I was one of the journalists publishing the RKI minutes, which is a very unique thing, because we could look into the conversations between experts, epidemiologists and others. We now know what they talked about internally and what they thought and what politicians said. And there's sometimes a huge gap now, even though politicians said we should follow the science. And I brought two quotes that I wanted to present to you that to me seem to contradict that it was also in the beginning a very deadly virus. I mean, deadly has to be determined, of course, but they say death rates, and this is March 21, so it's basically 1 year. They say death rates slightly below the average of previous years, possibly due to the absence of the influenza epidemic. No excess mortality is visible. So that's 1 year after. And then they say COVID-19 should not be compared to influenza, so they did dare to compare, but said it should not be. And then they say more people die during a normal influenza wave, but COVID-19 is more concerning for other reasons. But they don't say why. And I'm just presenting facts that critics of the measures always say. And then we also could say that hospitals in 2020 were historically empty. We didn't have more diseases when it comes to respiratory diseases. So how does this add up to a respiratory disease that is heavy and new? Isn't that a contradiction?
It's not necessarily a contradiction. I think that these notes are pretty fair and pretty accurate. So in Germany, indeed, there was no excess mortality in the beginning. There was some excess mortality later on. The exact calculation of excess deaths can vary depending on some assumptions that one has to make. For example, you have to use a baseline. What are the years that you're comparing the current mortality? Is it just the previous year, just before the pandemic? Is it 3 years? Is it 5 years? Is it many years? Do you model some change over time that you expect deaths to decrease? So if you expect, for example, deaths to decrease over time, then even if you get the same deaths as the previous years, you would say I had excess deaths.
Yeah.
But it's like, you didn't materialize some gain that who knows whether that gain should have been there. What we do see is that during the pandemic years, the best performance in Europe was by far Sweden. It had 4% fewer deaths compared to the pre-pandemic years once you adjust for the changes in the age structure, because you need to adjust for whether the population is becoming older and account for that. And Germany did not do that bad either. It was pretty far from Sweden. Germany did have some excess deaths, but probably in the range of 3%, as compared to, for example, the U.S. that had 12 to 13%. And U.S. was the worst among the countries that we have reliable data on death registration, along with Bulgaria. Actually, U.S. did worse than Bulgaria in the non-elderly population. What does that mean? I think most of the difference is explained by how functional these countries were, how well prepared, how good a healthcare system they had, how much of social welfare, and how little of marginalized, vulnerable populations they had allowed in their communities. And in the US, for example, we may have the best science in the world, we may have some of the best universities and medical centers, but we also have a large share of the population very poor, very marginalized, with no health insurance, with very poor access to health, who actually we did nothing to protect. We just let them out there homeless, with no support, to be massively infected and have very little access to good care. And therefore, we did see a lot of excess deaths. Many of these people ended in deaths of desperation. We had huge increases in overdose deaths. We had huge increases in alcohol-related mortality. And Germany had much less of that. It's not that you have the perfect society, but I think that you have a more evenly spread health system in terms of covering most of the population, fewer people who are really very impoverished and marginalized, and therefore the impact of both the virus and the measures that were devastating on their own was probably less compared to the US. Sweden did even better because probably they score higher grades on all of these aspects of social welfare and having a functional health care system and caring for everyone. They did a few things wrong in for example, allowing their nursing homes to be hit early on, but they covered that ground very quickly. And the deaths that they had in nursing homes were mostly of people who, now that we can look at the national Swedish data we have published on that, these were people who, it's unfortunate that they were hit so hard in the first wave, but their life expectancy was less than a year on average. So, if they had not died in that first wave, they would have died pretty much in the same year during 2020. And therefore, when you look at 4 years duration, that impact does not carry on for the entire pandemic period.
And it's also one point that, at least in Germany, the average age of a COVID-19 death was 83, which also was it's basically life expectancy or close to it in Germany.
In some cases, it was even higher than the average life expectancy. This is another dimension that has been a chronic debate in epidemiology. And when we try to calculate the impact of lives lost, you need to also add some estimate about what is the loss in life expectancy. And for different conditions, this may be quite different. So for COVID-19, it seems that the loss in life expectancy was very small compared to other conditions that people may die from. For example, if someone dies from a car accident,
Sure.
And they're very healthy, then you need to account for very large loss of life years. But if someone dies with multiple comorbidities and someone is in palliative care with 3 months expected survival, and yes, they get some infection, maybe that makes them die 3 months earlier compared to what they should have happened. That's very different.
Yeah. One of the key components of the pandemic years was PCR mass testing. It was a very important tool, I would say. And I come back to Germany, and I come back to the increase in risk, or saying, okay, we have high risk. And the public justification was, we have an increase in cases. But at the same time, this increase in cases was because people, or the state basically, tripled the amount of PCR tests being done in the population. And I was part of reading this about it, and then I just started to do calculations. I just did division and said, well, but if you divide the two, like how many were done and the positive results, from one week to the other, there was a change of 0.9%. So there was no tripling of cases or infection. It was just a triple of the amount of tests. And in the RKI minutes, the people there, the expert, they don't approve of mass testing healthy people. Even the vice president says, oh, there's a press conference, we should really say that it's not a good idea. So the test is so in the center of these years too. What is your opinion now about PCR mass testing? How reliable is the data we get? Because in Germany we had sentinels. They would bring data, how many respiratory diagnoses we have, what's the incidence, which is clinically relevant. It's sick people. So is this PCR mass testing a good idea if you want to monitor a disease, a respiratory virus?
So I think that one has to take into consideration in what circumstances and in what phase of the pandemic we are talking about.
Yeah.
In the early days, I was very disappointed that we had very little information about the spread of the virus. So I was among those who were arguing that we need testing. We need some systematic testing and try to get some estimates about the spread of the virus, try to have eyes on the spread of the epidemic waves in the community. And that was not happening. In the very beginning, probably we were underestimating the number of infections by a very, very large percentage. And I think that this changed over time to a situation where we had immense amount of testing, and after a certain point that became even counterintuitive and not helpful, and it just muddied the waters in terms of what the real epidemiologic picture was. It also added to the overcounting of COVID-19 deaths, because once you had a positive test, it was very likely that someone would be coded as a COVID-19 death eventually, even though perhaps COVID-19 was not a contributing factor, or maybe not one of the key contributing factors. And it was very often placed as the main reason for death. So I think that this sort of massive testing is something that we had not done before for any other type of respiratory infection. We knew that once you perform such massive testing, you're likely to get more false positives. You need to account for how much you have tested versus how much you tested before, to try to get a sense that is more balanced about the evolution of the epidemic wave. So even though in principle it was an interesting idea, it ended up being misused. And of course, it ended up using billions of dollars and euros to do all that massive testing and to continue it even after a certain point where probably it had lost its utility. The virus had been very widespread. Almost everyone had been infected. very often multiple times, and it made no sense. I think we failed to use testing systematically early on, which would have made a difference because we would have known much better what we're dealing with. We failed to use it explicitly in some high-risk settings, like nursing homes. Somehow the first waves hit nursing homes and killed so many people without having the benefit to have eyes on the spread of the virus. And then it was misused to massively test again and again and again populations that really didn't get a benefit from that.
So the way I understand it, in the beginning, it was really good to really find out what are we dealing with in terms of infection fatality rate, as also Professor Streeck did here in Germany, who did a study. We need to know the ways of infection, and we need to know how deadly it really is. And maybe once that was relatively clear, it would have been better to do another testing regime that is more focused on something. It seems
focused on people who are at high risk. I think that we failed to protect those who are at high risk, unfortunately. So we got the brand of the impact of the virus on these people, and at the same time, we were protecting more people who didn't need to be protected in the same way.
One thing that people, I talk to people saying, I would interview John Ioannidis, and they had some questions. So one thing that comes up again and again, and it also comes up in our media, is that we had like pictures of, it was called Bergamo, like where there's, the picture wasn't quite right as we know now, but it's not very important. But people are confused or interested in, we had like a peak of excess mortality in New York, I think, and in Bergamo, or northern Italy, basically a region. Do we know now why just at these spots there was such a high peak of death? Was this just related to COVID, or was there anything else? Because it seems strange that just in one place there's such a high peak.
So some of the early experiences were devastating, and I think that it was a combination of multiple factors. We knew very little at that time. I think that we did not manage to protect people who had to be protected. It was even inverse protection. I think that those who were vulnerable were even more heavily affected in these settings. For example, in New York, we were sending infected people to nursing homes. So we did our best to maximize the impact of that wave in New York. And in Bergamo, again, early times and no knowledge about what to do, how to treat this, no effective treatments available, perhaps some overreaction, unprepared health systems, management probably suboptimal. I have been attacked about this claim that, you say that physicians killed people. I think physicians were heroes in these circumstances. I'm not interested to blame anyone, but in every situation, if you deal with a new condition, with a new process, with a new set of interventions that you need to do, you have a learning curve. So your first results will not be very good. Think of this like a surgeon who is trying their hands to do an operation for the first time. Their likelihood of something going wrong is pretty high. And then the second time is a little better, the third time is even better, and so forth. And I think that probably in the first wave, in these places that were so massively hit, we just didn't have good results. We just didn't use our technology and our medical infrastructure in a way that would make a positive difference. Perhaps we even made a negative difference. And I don't say that to blame people who were in the front line. I'm an infectious disease person. I saw many people with COVID during the pandemic. I know how heroic my colleagues were who work with COVID-19 patients. My wife was a frontline physician, also in infectious disease. So I think that our outcomes were very poor.
And just to echo that, we have a chief physician in Germany, his name is Thomas Vosshaar, and he has at the Clinic for Pulmonary and Bronchial Medicine at the Betanin Hospital. It's not very important, but it's in MERS. He's very famously because he talked about the effects of premature invasive ventilation. And he said, and he's not blaming anybody, he said he estimates that at least 20,000 unnecessary deaths have been caused by basically premature invasive ventilation. So it echoes what you said. There was uncertainty how to deal with it, and it might not have been the best
We don't know. I think that this is an interesting estimate. I cannot put a number to this because no one can really understand the microenvironment, what happened within each hospital, and what happened in each case in terms of the management. But it is understandable that we were dealing with something that we had no clue what to do and how to deal with that in the most efficient way. Plus, we had no interventions that would be effective that we did get within a few months. So dexamethasone, which was effective, was demonstrated to be effective in a large randomized trial within a few months from the first wave. So it didn't affect the first wave, but from the second wave onwards, we could have that option that would probably decrease death by about 20%, roughly, if we could use it, or perhaps even more in some groups of patients. So I think there was a learning curve, and I think we did lots of things wrong in the first wave. Again, not to blame anyone, but panic and overreaction probably did not help in any way.
Yeah. I would like to go with you to the measures that took place. Before that, how roughly when would you say, when did you have enough reliable data that you could say, I think we are not dealing with a killer virus, how it was told in the media? Like, was there a point? I mean, I just said it in March. You already said, the IFR could be way lower than we think. But was there a point where you thought, okay, now we have enough data to say we should not panic here? Was there a point?
I think that probably we had pretty solid data by April of 2020. We had some preliminary information even before that. For example, we had data from the Diamond Princess cruise ship that we could get some rough estimate about what the infection fatality rate might be. But then by April, we had several seroprevalence studies, both in the US. My team and my colleagues, we did 2 large seroprevalence studies in Los Angeles and Santa Clara, which is the county where Stanford is. In Germany, there was Gangel. There were other seroprevalence studies also done at that time. So we had a clear sense of both the average risk, which was not very useful, to be honest, and the risk gradient, which I think was more interesting, because the risk gradient suggested that we did have a killer virus, but focused on specific segments of the population.
Especially the old ones, right?
Very old people and very debilitated people. So these people were at very, very high risk. Conversely, for the large majority of the population, the risk was very, very low. So we knew that pretty much by April of 2020. And I think that we could have adapted our response based on that back in these early days. I think it was okay that we did what we did in February or in March, but I think by April we should have changed course.
One of the things that I found really interesting is that in the RKI minutes, there's the note of an RKI member coming back from China in end of February 2020. And he says, we had a huge study here. Children are less in danger than from influenza, and they don't spread the virus heavily or significantly, he says. And that's in the end of February, and we had school closures in mid-March. So I found it interesting that in the RKI, there was at least some evidence suggesting we should be careful what we do with children. I will ask you about this, but it struck me because I was working with children. I was not a fan of closing schools and kindergartens. And then I read this and said, well, it's the end of February and you have evidence that children are not in danger. I didn't know. Why didn't nobody tell me, officially at least? So then these measures came into place, and several measures, and this word lockdown doesn't really work because it was so different in so many countries. I understand that it's not as easy as it sounds, but you have done a study that basically reevaluates, if I'm right, a study by the RKI, which is called Stopped COVID. I did an interview with an author of the study, and the study from the RKI claims that the non-pharmaceutical interventions helped slow the spread of the virus significantly, which was their goal, that was their intention. What did your evaluation find out about the effectiveness of these measures in Germany?
So we tried to reevaluate the statistical model that was used by the RKI colleagues, and we also tried to use different approaches with different modeling of the same data sets to try to see whether the results are robust and whether you get the same conclusions with these different approaches of modeling the data. So the basic conclusions were that the RKI results are probably not trustworthy. I think that they underestimate the uncertainty around the estimates, and once you properly use the methods that they try to use, their conclusions are probably not there. Right? I think they vanish. And when you use different models, which I think many of them are more appropriate for these types of data sets, you see pretty much the same conclusion that hardly any of the measures do we have evidence to say that they did make a difference for decreasing the number of cases. We're not talking about impact on deaths. We're not talking about impact on any collateral damages. We're just looking at number of cases. But even for that, I don't think that we have solid evidence for any of the non-pharmaceutical interventions that they made such a big difference. The strongest evidence might be for restriction of the number of people who would be in public events, which I think made perfect sense in the peak of an epidemic wave. You don't want to have 50,000 people mixing with each other in very limited space. We did see seasonality, for example, that had some impact, which again is something that is understandable, but not really much in terms of an effect of the non-pharmacological measures per se. And this is something that has been seen in many other evaluations. Very early in the pandemic, my team published another paper where we tried to reevaluate what the modeling by Imperial College had suggested. So Imperial College published a paper claiming that in the first wave, these measures saved several millions of lives by stopping the epidemic waves, far more compared to any other intervention that was more restricted and more limited. So we looked at what they had done, and we also used another model that they had developed. So they published one model on the European data, and they had developed another model that they had applied to the US. So the second model fit much better to the European data. And if that second model were applied to the European data, then the aggressive lockdown had absolutely no benefit, practically. So the modeling can make a difference. And if you use a suboptimal model, you can come up with very weird conclusions. There's other work that has been published. For example, some of my colleagues at Stanford and Harvard have looked at 100,000 different models. And their conclusion is that 60% of them suggest that the aggressive lockdown measures increase the number of cases.
Wow.
40% suggest that they decrease the number of cases. Usually the impact is pretty modest. It's not huge, but it's more models that suggest an increase rather than a decrease. And of course, this is just number of cases. So a number of cases, I don't want to say nobody should care about, but it's really a very soft outcome. What matters is impact on real health outcomes. And if we go in that direction, then I think that aggressive lockdowns were devastatingly harmful. I mean, not just equivocal. I think that they were devastatingly harmful.
I mean, it seems so. Basically, it's shocking. I mean, I know these studies. It's not new for me, but still hearing it, because thinking about what we have been mandated to do in Germany, for example. It wasn't like people suggested, hey, why don't you not gather? Like in Sweden, for example, but people were mandated all these things. And now to hear the evidence right now doesn't show any benefit when it comes to spread, because that was the word. We have to stop to spread the virus. And this is why you have to mask up, you have to have your children at home, all these things. And then it seems like we don't even know if that works or if it worked. It seems almost unimaginable. And these findings that you're talking about are not just for Europe or Germany. These are findings that I mean, of course, because this works globally, it's the same globally, right?
I think that by now we have a very extensive literature, and I cannot promise to you that every single location in every single country would be the same.
Yeah.
Because obviously you have very local circumstances that you may need to respond a bit differently. But it doesn't seem that what we did, that extra effort of trying to completely block any activity really made any positive difference. We know that it did a lot of harm, but it didn't really make any difference that would be positive. This doesn't mean that I would argue that, so next time everyone should be out there and we should have massive events with 100,000 people in a closed space, and people should try to get infected. Because, some of the critics of those who said that lockdowns did not work think that we advocate that, let's get everyone infected right away.
I know.
This is completely crazy.
Yeah.
And people did respond. They heard that there's a threat, and they did take their, let's say, private, personal measures to try to avoid probably some extra risk that they would not have worried otherwise. So probably what they did on their own was already at a level that would be good enough. But some people could not do this because of their circumstances, because they were very poor, marginalized. They had to work, they had to be out there, they had to be exposed, and they had no support. So these were the people who we had to take care of and try to protect and do something for them. And if they had problems, give them the care that they needed. And we did none of that. We just increased the risk for these people. And we just shut down those who did not need to be shut down. or we thought that we would shut them down. In fact, you cannot shut down humans. Even Ferguson went to see his lover.
Yep.
So it's human nature. You cannot just put yourself in a closet and lock the door and stay there for 3 years. It's impossible.
Yeah. And did the RKI respond to your findings? Did you have a discussion with them?
Not that I know of. I need to check if if something has happened in the meanwhile, but not that I know of.
Okay. And from a public health standpoint, was it? If you put these measures in place, probably people wonder, what's the literature about these measures? Like, how did we deal with pandemics before, with respiratory viruses? And the pandemic plans we have in Germany, they didn't say these harsh measures. They can't be found. They cannot be found in there. So, wasn't it to be expected that the outcome could be so devastating from what people or how people dealt with viruses before?
I think that our pandemic planning did not include this type of response. I think actually it was something that had been vetted and had been discussed as a possibility and had been rejected.
Yeah.
And I think that was pretty much the case in Germany, in the US, WHO. I think everyone had agreed that if that were to happen, we will not go down that path. It doesn't seem to be a good idea. I don't think that anyone had predicted exactly how much damage we would do, because obviously the ceiling of damage is impossible to measure. We can commit suicide as a society, and I think that unfortunately this is what we did. We committed suicide, and there's no end to how much damage you can do once you start going down that path. You can make all sorts of faulty decisions and just keep reinforcing this wrong decision making ad infinitum.
What was for you the most shocking benefits or collateral damages of these measures? Did you find anything where you said, wow, this is so tough, or this is so strong, or you wouldn't have expected it to be that bad? Was there anything?
It's very hard to choose because we saw so many disasters. We saw major disasters in our educational system, in children left out of school, major problems with mental health, massive increases in overdose deaths in the United States and in other countries as well that didn't have such a big problem before the pandemic. Major increases in alcohol-related deaths, disruption of cancer care, increase in cardiovascular deaths because people did not even want to go to the hospital to get treatment for myocardial infarction, disruption in the economy. I think what we see now with all these tremendous financial problems and inflation and cuts in so many vital areas of societal well-being and resources that are not available any longer. I think that these are all consequences of that wrong decision-making that happened in these 5 years.
I just read a survey in Germany that 70% of young people agreed that it brought them more social isolation still. So they still feel more socially isolated than from before, which is, I think, also a high number and frightening.
It's very likely that we will see some protracted impact of the negative consequences of what we did. It's unfortunate that many people saw that as an opportunity to transform society. So they probably saw that, oh, now that's the opportunity to move into a situation where people work from home and we do not commute and we can have more time at our apartment and we can just have Amazon bring our food every day instead of walking out to do the grocery. Completely utopian and maladaptive, I would say. And even respectable institutions, major institutions, kind of backed up this sort of utopian transformation of society that I don't think it's fit for humans. Maybe it's fit for robots or for some sort of artificial life, but I don't think it's fit for human beings.
You're still social creatures.
We are social creatures for good or bad.
Yeah. You already mentioned it. Sweden. Sweden was highly debated here, but it is like not close neighbor, but it is a neighbor. So for some people, it was sometimes hard to look at Sweden, especially after a while, because they were saying, oh, if you do this, and I think Neil Ferguson and the Imperial people, they also estimated how many people would die in Sweden if they don't lock down, but they didn't do, and also they didn't get the numbers. So why on earth did Sweden stick to pandemic plans that were in Germany also too, like were normal basically? Why didn't they go into all these measures? Why didn't they use them?
It's hard to tell, but there may be many explanations. One explanation might be that their constitution does not allow for the type of measures that were taken in other countries. I think that they did not panic. I think that they had very reasonable people at the helm of their public agencies. I think that most of the population trusted their scientists and their public health experts. And they're a society that has very high sense of social cohesiveness, of the importance of social well-being. They have a health system that is pretty functional. They made some errors. I think everybody made errors, but overall they did so well that, in that paper that we published in the Proceedings of the National Academy of Sciences in the US, we saw that they had the best performance compared to any European country with -4% excess deaths. Not excess deaths, but death deficit during the pandemic versus the pre-pandemic year. They were the best actually worldwide, along with New Zealand, which is interesting.
Because New Zealand had hard measures.
Well, New Zealand had hard measures, but practically they are an island country, and they just shut their borders. They didn't have an epidemic wave practically until Omicron. And Omicron was a virus that had much, much lower infection fatality rate. So the question is, could Germany be New Zealand? Could the US be New Zealand? I don't think that that would be feasible. I think it was a very different setting and a very different possibility to say that, okay, we will close our border and wait until we have a better virus circulating, that then you get some impact, but it's not really that bad.
My last, or almost last topic, but strongly related to the measures, is the vaccine that was introduced, because it was sometimes connected. We need time for the vaccine to be there, so we have these measures. And to me, it seems, after reading a lot about it, vaccine efficacy and safety, especially when it comes to COVID, is almost as emotional and as tough of a topic as the measures have been in the first place. Like, you are an anti-vaxxer or you are just all vax. It seems I sometimes don't understand why people go into completely black or white mode if we're talking about a treatment that somebody wants to take or doesn't want to take and is basically searching for information. So is that only my perception, or how do you perceive the debate, also the scientific debate, around the efficacy and safety of the COVID-19 vaccines?
That's another polarizing issue. And indeed, as you describe, there's again tribes and clans of people who say that vaccines saved 20 million people during the pandemic. Even within a few months, they saved 20 million lives. And others who say, no, vaccines killed 20 million people. And again, one has to belong to a tribe, otherwise they would be attacked and they would be outcast. And I think that this is very unfortunate. I think this is a big problem. I see that as a consequence of the toxicity and the buildup of tension that was created by the initial response, that polarized communities, and then people had to continue on and find the next culprit, the next force that was destroying their lives and killing people, and it had to be vaccines, or they had to find a savior, which was vaccines. I think none of these two perspectives are correct, even though I would be attacked by both sides. I think that I don't believe that the vaccine saved 20 million people within 10 months, as a paper in Lancet Infectious Diseases has estimated, making some completely implausible assumptions of modeling, blatantly wrong, in my opinion. And I don't believe that vaccines killed 20 million people and they're responsible for the excess deaths that we see. We have excess deaths, but I think that they're the consequence of the fact that we did horrible things ourselves during what was a pandemic. So I think that's what you get. You don't need to claim that it's the vaccine that is killing all these people. We have made some estimates based on what I think are reasonable assumptions. And I think that there's room for debate, that some of our assumptions perhaps may not be so accurate and may need to be revised. We have better evidence. But my calculations suggest that vaccines did save lives in the net balance. We estimate 2.5 million lives saved over 4 years globally, which corresponds to about 1% of global deaths during that 4-year period. And I think that there's uncertainty around this. It could be between 1 and 6 million. If you start considering different factors that may have some sensitivity range. But I think that you need to account for differences in risk in different subsets of the population. So probably elderly benefited the most. And I think that most of these lives saved are in people who were elderly. When it comes to children and the young adults, I'm not sure that the benefit was necessarily more than the harm or the cost. It's something that one has to look very, very carefully to see whether it did make a difference. But I don't think that it is such a stark picture of 20 million lives saved or 20 million lives dead.
In this paper, where you say a major overall benefit from COVID-19 vaccination during 2024 is the sentence that I wrote. Did you did you incorporate adverse events or deaths from the vaccine in those estimates?
Deaths from adverse events, our estimates suggest that they're probably in the range of 20 to 50,000 globally, which for me, every single death counts. And this is why I say that these numbers need to be interpreted in the context of what does it mean for different age groups and for different settings, because the benefit for children and for young adults is very, very limited. So you need to balance that against deaths or other consequences from adverse events, and also against the cost, because obviously we cannot have infinite resources. We need to apply our resources to things that work and are effective and are cost effective as well. Conversely, I think in elderly people in the early years, vaccines were a good idea. Are they a good idea now? I mean, that's a completely different story, because now the risk of negative consequences from SARS-CoV-2 infection are very, very low. So I don't think that you can extrapolate that to the current situation. But one has to be very, very cautious about generalizing and saying that this was the greatest saving measure, or that was the greatest destructive measure that one can imagine. I think the truth is somewhere in the middle between these extremes.
There's a paper that you wrote about influenza vaccine and COVID-19, about the efficacy. And there's a sentence that says the fact that both influenza and COVID-19 annual vaccination policies rely on observational evidence is problematic. In both cases, what is most needed is robust effectiveness data on important clinical endpoints, such as severe illness, hospitalizations, and death. So the study for the COVID-19 vaccines, their main primary endpoints were not these clinically relevant aspects that you say.
Indeed.
And also, as Peter Doshi said, because I wrote his work on this, it didn't show an overall benefit for death, for all-cause mortality. And if I understand your work right, what is needed to know something, high-quality evidence, means randomized controlled trials, because observational data has the biases that you write in this paper about. So what I wonder, there was this randomized controlled trial. It didn't show a benefit for all-cause mortality, which I would expect from a treatment that saves so many lives. Isn't that a contradiction?
So the randomized trials that were performed for COVID-19's in the pre-licensing period were not aimed to show mortality outcomes. They were completely underpowered to do that. They focused on symptomatic infections. So we did see a very clear effect on infections in the short term. And that was what led eventually to their authorization, and then downstream to their licensing, once we had also some observational data sets suggesting that the patterns are consistent with very substantive benefits, not only for infections, but also for hospitalizations and for deaths. Observational studies have limitations. This is unavoidable. This has been a debate within epidemiology for a very long time on how much we can trust observational studies. If you ask a really excellent epidemiologist, very well credentialed and thoughtful, they will take different positions in a spectrum from observational studies are as trustworthy as randomized trials, and they actually may be even more trustworthy because they look at real-world settings, while randomized trials have an artificially selected population, all the way to observational studies are completely a waste and misleading, and have proven misleading so many times. I think that there's some right points on both sides in different circumstances. It's difficult to operationalize that for COVID-19. I think that the magnitude of the benefits seen in observational studies for COVID-19 has been very stark. So it's not easy to say that this is all bias. What we also see is a very clear decrease in the benefit over time. And after a certain period, we see even a reversal of the benefit. We see some point that that huge benefit, for example, even for infections, goes down to zero and becomes even negative after a certain point. We see a decrease also in the benefit for hospitalizations and for deaths. So that's what we have at the moment. We have evidence that has modest reliability, suggesting an early large benefit with very sharp decline over time. And I do believe that we need randomized trials. Now that we're dealing with a very mild infection, in the vast majority of cases, I would say we need it even more. I cannot give a blanket recommendation to have some sort of COVID-19 vaccination program, let alone mandates. I think mandates were wrong throughout the pandemic, because I don't believe that this is the way to really lead to better outcomes. You may force some people to do something in the short term, but then you make them angry. You rightfully angry that you force them to do something, and then they don't want to do even things that we have much better evidence, like using MMR, for example. So I believe that we could get randomized trials done. There are examples, for example, of such trials done in Denmark. People have counter-argued that, each year we need to move very quickly. We don't have enough time. Well, these trials can be run very quickly. They can be run within a month or two with very huge population sizes, sample sizes, and they can be very informative. So they can tell us how much we can expect and whether it is worth to use in everyone, in a subset, just the very old, or whatever is really the best solution. We haven't adopted that approach. We just go blindly, and each year lots of experts get together, very good people, and they need to make a decision. But it's expert-based science, and expert-based science is not really
high
the
quality,
most reliable.
Yeah. Okay. And I was wondering, because the studies that led to the authorization, they were unblinded early on after some months, right? Because if those randomized controlled trials would have stayed for years, we would have known better. Are there any deaths in this group? Do we have any diseases more in this group? And this data we don't have right now.
It's unfortunate, because we had an opportunity. I don't think we would have had the perfect answer, but we would have had some more evidence based on that initial randomization and the intent to treat, with caveats. But I think that would be valuable. I think many people argued that we should try to maintain these randomized cohorts, but unfortunately there was so much panic and so much screaming, and it just didn't happen. So one more consequence of not being able to think in a cool way, with a cool mind, but just jumping forward and saying, stop it, everybody now should get vaccinated, and this is the one goal of our society. And yes, I think it was a major success that we got vaccines so quickly. Most experts did not believe that we would be able to get vaccines so quickly. But then, what a disaster on how we implemented and how we translated that message for the community. Perhaps we made friends and convinced some people who were already convinced, and we made enemies of those who we should have done better to try to convince. And that split has remained. At the moment, it has become intensified even, and you see that extreme opposition of views that vaccines are the best thing that ever happened to humanity versus they're the worst thing that has happened to humanity.
That's also the topic, or my last point that I was interested in. Here in Germany, it's clearly to see that people lost trust in politicians, and they also lost trust in science and in public health figures heavily. And there's a lot of people that still want the measures to be reevaluated. They want to be talked about it. They want this time to be thoroughly investigated in a way. What's your take? How is it in the US? What do people also want that this time is looked at still?
I think that there's lots of people who would like to know better what happened and what we did right and what we did wrong. I think this is a global kind of request. At the same time, most people probably have moved on, and probably this is a good thing. I don't think that we can ruminate forever, especially if there's no willingness to be objective and no willingness to just sit and reevaluate in a calm way with decency and decorum what we did right and what we did wrong. Um, I don't know whether we will see some honest reevaluation of what has happened. We have this massive literature. We have 800,000 papers in the peer-reviewed literature out there. So it's not that we don't have evidence. And in my experience, even in less controversial areas, the inferential reproducibility, what experts make of a set of results, can vary quite a bit.
Yeah.
They can disagree. They may be looking at the very same numbers, at the very same studies, at the very same numerical results, and they may be interpreting that in a different way. I don't think that we can force someone to change their mind if they want to look at a number that is a 5 and they read it as a 70. But at least we can make it very clear that they're reading a 5 and making it a 70. So transparency in information, making evidence available to be scrutinized, and transparency in the chain of interpretation of different experts or different stakeholders, I think is nice to have, because then people can decide. They can say, Johnny Ioannidis is looking at these numbers and goodness, he's so wrong in interpreting them in this way. Isn't this obvious that this is a 5 and he says that this is a 70? So I think that that's something that we could aim for. And I wish we could find ways to de-escalate the toxicity, to have people be more willing to talk with each other if they belong to different parts of that divide. Perhaps have a few people move from their initial positions. That would also be nice. But if it doesn't happen, what can I say?
Yeah. But I think it's true for Germany too, in a way, what you say. At least I see it that way. My last question is maybe more a little bit of political nature, because in the US, there's, of course, with the new administration, there's changes. And there's also Jay Bhattacharya, which you probably very well know, your colleagues, and he has been very open about his opinion about the measures. He probably will have an important role and will be nominated in the cabinet, I think NIH director.
NIH, yeah.
Do you see or foresee now any changes in public health with this nomination and the changes happening?
I think that there's a lot of uncertainty because it is not really just Jay Bhattacharya. It is many voices and many stakeholders who have very strong positions and very strong expectations and priorities, and they may want to push for their agendas. So I don't think that it is really up to one person, no matter how good or honest or credentialed that person might be. I have very high esteem for Jay Bhattacharya. I know him since 2010 when I moved to Stanford. He's an excellent scientist. His work has been very thoughtful. It's interesting that he was always the introverted, ground-level, quiet scholar with no access to social media and never wanting to promote himself and to show himself in media. So during the pandemic,
that changed.
we started doing research on these important questions, and very quickly we realized that you could not win the scientific debate with scientific evidence. We were attacked right and left by people screaming who wanted to kill us and destroy us and eliminate us in every possible way. So, my decision was I don't have Twitter account, and I will still not have Twitter account. I will not go into social media. I will just continue doing research and publishing papers for whatever they're right or wrong. I think Jay at some point said, that doesn't work. So he opened a Twitter account. He got 600,000 followers to that. He started appearing in legal cases and litigation, and which I also avoided, and engaging in the political aspects of the debate. And now I think he has a chance to make a difference. I hope that retribution and retaliation are out of the question, because I cannot think of any worse outcome other than one party trying to get revenge from the other. And I think that this is what we see at the moment, unfortunately. But there's so much toxicity, and science has been embedded so much into political partisanship that I do worry. And I see that in the United States. I see that in Germany, in Europe. It seems to be a very worrisome trend, and I feel we need to do something to revert it. Science needs bipartisan support. Science needs to be independent from politics. I think we need to gain back trust and respect that we're doing our best. Science is very difficult to do. We can make errors. I feel that we're immersed in error in trying to do science. But we should convince people that we try to do our best, that we're not really just doing this because we somehow are part of that political party or that big tech or that big pharma or what other coalition. We do it because we want to help people, we want to save lives, we want to get closer to more accuracy, to the truth eventually, even though this is an asymptomatic goal that probably we will never reach 100%.
I think these are great final words for our interview and talk. Appreciate you taking the time to talk about these complex and very relevant issues. Thanks.
Thank you so much.